welcome you all for this very interesting and possibly a needy session on public health at cCep initiatives by Nishith Desai Associates. And thank you very much, all the panelists, for agreeing to spend your time to share your views on this important topic. I'm reminded of an quote by Owen Arthur, and he said that for he who has health has hope, and he who has hope has everything. Now, health leads to hope, and hope leads to everything. Do people in India have that hope? Do people in India have that everything? And that is where I think the public health India is going to play a significant role. Now, what exactly public health is? What we will discuss today. Now, when you talk of public health, immediate thing that comes to your mind is that government does everything. Government gives and provide total free service, or it could be a mix or a blend or a conglomeration of all the activities done by government to prolong life, to cure diseases, prevent diseases, at the same time promote health and increase the efficiency of people at large. And that is what I think the healthcare is really about. Now, India is really interesting situation, and whether you take US, UK, or some European countries, they possibly have robust healthcare. Possibly, people used to say this before 20th of January, but now I don't think any country would say that we have a robust public health system in view of the COVID-19 crisis. Now, when you talk of India, India is a very interestingly placed healthcare scenario. Highly fragmented. I was a surgeon. We have Rajiv Bhatt, who's an oncosurgeon, who also agree that we have rural to very urban divide where there is a tremendous need for public health. There are certain places. Government also has come out with very interesting initiatives like Ayushman Bharat. I'm expecting Ayushman Bharat 2.0. States like Gujarat have schemes like Ma Card. But whether this really serves the purpose, it is definitely serving the purpose. But what is really happening in India is that almost 75 to 90%. I know it's a big delta, but this is what I personally feel that almost 80, 85, 90% of the healthcare is private and hardly 10% is public. And what is the real challenge in India is that the perception, the by and large perception, even at the remotest area, is that the quality of public health would not be great. And that is why they are inclined towards private health. So I don't say private health is always qualitative or really serves the purpose, but what I think is required today is a ratio of 90-10 to go to maybe 10, 90 towards public health may not happen, but at least equal public-private scenario that happens in next few years to come. And I think and in India it's not going to be uh, easy job. India will have to come out with very different models. Unlike giving everything free, may not be possible. Coming out with some reimbursement program may not be possible in every state. So I think we need to create a very interesting blend. And I'm so happy today that we have Nachiket more who breathes public health, who lives public health. We have Amit Chandra who has done excellent work. I worked with him on a lot of activities, how in government initiatives take place. We have Anand Bang, who along with his father works in a remotest area of Gadchiroli, and maybe because of the remotest area, he is not able to join on video because of the bandwidth issue. It's raining cats and dogs and elephants. That's what we discussed just now. And we have Rajiv Bhatt. He is my batchmate from my college, but he was a private practitioner to corporate practice to 4 or 5 years of stint in South Africa as an oncosurgeon. Now he leads the entire HCG center of Baroda. So we have a very interesting mix today to talk about public health and how exactly we can move. We are going to start just with 5 years. So I think we are going ready for that. But before that, I would request Nishit Bhai just to welcome all the panelists and the participants.
Yeah, thank you very much, Dr. Milind Antani. Wonderful, initial statements, and thank you so much, Amit, Nachiket, my good friend, long time, Anand and Raju and everybody. It's so nice to be together here to discuss Circa 2025 on public health system. And there's so much that needs to be done that can be done. And I think, we always talk about potential, but I think realizing the potential is the most important thing. And sometimes I wonder, it's Public health is just not, as Dr. Milindani indicated, it's government's job. I think it is more for us to do. Also, one small thing that always bugs me is that I believe we spend almost $60 billion on defense, about 15 million on education, and 10 billion. I don't know, number may have changed a little bit after COVID, but $10 billion on healthcare. I think so. Maybe there is some rethink about how do we go about it. Everything is important, but I think yeah, health gets a different level of attention. Now, after COVID, things might have changed probably, but we should try to see how we can build different business models as well. Second point is that CSR funding, again, that can be directed for both not only the charitable work, but also if 10% of CSR is allowed to be invested in impact funds or impact investment in a measurable and accountable way, I think we'll achieve a lot. I think that's what I think Nachiket, I remember those days, if I'm not mistaken, you're talking about microfinance. Most people thought it was like charity and stuff like that, but I think it has really helped so much. You can talk a little more about it, but we can find some new business model to leverage the the whatever little finance or the infrastructure that we have. Third point I always feel is that there is so much assets that is sitting doing nothing or doing very little. So can we look at models of mergers and acquisitions in not-for-profit sector? We all corporate lawyers do all this kind of stuff, but I think it's very important to see that if we can have consolidation in and create an ecosystem for that, we'll create a lot more infrastructure. There are some NGOs which have simply money, because everybody, when somebody dies or something like that, they will put some cash money. Children will keep that in the trust and keep on doing the business. There's a lot of cash sitting there. Some NGOs have only people. Some NGOs have infrastructure. Like as you go to villages or schools, or in primary health clinic, or in cities, wherever, you know. uh, But just land is sitting, infrastructure is basically sitting, but no equipment, no other kind of stuff. And there are, other NGOs which have everything but no management skills. And as a result, what happens is that we have a lot of fragmented approach, a lot of asset locked up. So if we can unlock the potential of coming together and consolidating and creating some new models around that, so that is how we can build some capacity and I would say on competencies and stuff like that. In fact, one thing that has happened, pandemic, of course, has been a very sorry event that has happened, but it has also taught that we can do a lot more now through technology. I think everyone in city and village is now capable of being educated through cell phone and through and the power was there. We knew about it, but this pandemic has really forced us to use that power. And we see Nachiket, I could meet after about 20, 25 years, I don't know how many. And, we can sit and talk and ideate. So I think this power of technology we can leverage. AR, VR can teach a lot how to treat patient, what is a We don't have a system of paramedics at the moment as much possibly. And so we can have more systematic approach to training, skilling, and stuff like that. And my personal feel is that more than manufacturing, the service sector can create more jobs. I think there is little myth that only manufacturing can create jobs. What I believe is that services sector India already has 70%. And if we leverage our historical strength, we'll do it faster, better, cheaper. The investment is less, output is more, value addition is more. In manufacturing, you import a lot and then value addition is less. So I'm not against manufacturing at all, but I believe that we should not forget that service sector can create huge amount of employment as well. We use of drones, and we have done a lot of studies around that. And drones will create largest number of employment because no unmanned drones permitted. So we can discuss those possibilities. I don't want to take your time, and I'm sorry I've extended introduction to some of my thoughts, but it's so nice to see you all, and thank you so much for finding time to be with us. Let us continue to stay connected like this. Thanks a lot. So welcome all. Welcome all the attendees who are attending. Is large number of people who have gathered on to discuss today's proceedings, and because everybody is concerned about what next in next few years now, what we're going to do. And you all have so much experience you'll be able to share, and look forward to hearing you. Thank you so much. Welcome once again.
Thank
Thanks.
you. Thank
Nishith,
you.
that was a very important point that public health is very important, but at the end, buck stops at us possibly, especially with reference to India. Now, I think, public health has become very crucial. And I think, as you rightly mentioned, Nishith, by that the present pandemic has taught us a lot of things. I'll start posing a question to all the panelists, that everybody has realized, not even common men, but even doctors and hospitals have realized the importance possibly of public health. And public health, we need to define. And I mentioned that I don't want just go to free service anything. It could be public-private partnership or some kind of interesting model that emerges in next few years, and ultimately we enter the what exactly the public health should be. So I just have one simple question. I'm not starting on a negative note, but what are the lessons that we have learned from present COVID crisis, mainly from public health point of view? So I'll start with you, Nachiket, first. Your views on this.
So I think, the crisis is not over yet, and therefore the lessons that we're going to learn will still take us time to fully internalize. And I think one thing that certainly became obvious fairly early, that is strategy in which we basically cut paste European ideas into the Indian environment, where we try to centralize patients, build ventilators, build ICU beds, wasn't really the best direction to have gone. And of course, as I said, the crisis is still ongoing. And I understand now Bihar, UP, many of these states are starting to show numbers that we need to worry about. But the Italians from Lombardy had warned us well, much earlier, that this crisis has to be dealt at the community level. It has to be dealt close to where people live. As Nishith Bhai was saying, maybe even at home, and really, what can we do there, rather than thinking about this as a regular cardiac crisis or renal failure, in which we are transporting patients to the best possible facility. And it was not surprising that many cities ran out of capacity to respond to these issues. So I would say it's clearly one lesson. And as we go forward, we know some characteristics of the disease. We know, for example, it disproportionately impacts older people in terms of mortality. Simply issuing circulars and diktats is not going to make people wear the masks that they need to wear. You have to work with the local structures. For example, I live in Bangalore. I find the Bangalore municipality is doing a very nice job of engaging with housing societies to make sure that, in a sense, trusting the housing societies to become the eyes and ears and helping the government think it. Something similar, I would say, would be necessary on a nationwide basis. So I will stop here, but I would say these are some of the early lessons that at least one can say from the crisis to this point.
Yeah, very, very important, very relevant point. So, Amit, you have been working at multiple levels. I've seen you working on a very interesting causes also. So, your take, what are the lessons you are learning? I'm changing the question, not learn, but learning from the present COVID crisis. Amit.
Yeah, thank you, Milind. Thank you for inviting me to speak as well. It's tough to follow intellectual giant like Nachiket, but I'll make four observations more as a practitioner. Given our foundation has been very involved in fighting the disease in Mumbai and to some extent in Maharashtra. And I agree with Nachiket. I think it will actually be a long while, even after this crisis is over, that we fully internalize what the learnings are. We are probably only halfway through understanding what the learnings are. I would say the first key learning in my view is that undoubtedly, prevention is actually much cheaper than cure. And we see this in Mumbai. Governments, for long, governments have not been understanding fully the need to really invest more aggressively in prevention. For example, in Mumbai, for a long time, people have been working on the whole need to invest more aggressively in urban development. And I think we've paid such a massive price during this pandemic for the entire slum situation. I think a big issue across India will be the lack of investment in public health infrastructure. And that will be a key learning. So I think, Nachiket did some great work, for example, when he was heading the Gates Foundation in India on Swachh Bharat. And we'll realize actually that was a great initiative which would have helped this time around. But in urban areas, the fact that we still had hundreds of families sharing a toilet in the slums, it actually land up having costed us enormously. So when you really step back and you'll realize that prevention is actually the cheapest way. And over time, if you do not invest in prevention, societies can play a massive multiple of costs. And there are many other crises that we are going to face in the future if we don't start correcting them, in climate change, the arms race. There's inequity of all sorts. If you don't invest in addressing inequity, you will actually have other kind of revolutions. There are many other ticking time bombs. The pandemic was only one of them. So I'd say that is one big learning in my view. The second, I think Nachiket already talked about to some extent, which is really the need to invest very aggressively in collaboration, because communities are critical. We have seen in this case that wherever communities and governments have worked together, we have seen great results. Kerala, in my mind, to some extent, was an example of that. Even in many other places, there are micro examples of great investments, of great success stories where communities have collaborated with people. Where masking has happened really because it wasn't a mandate, but because communities did it. Where people did very good quarantining, even within Maharashtra, for example, where quarantining was followed uh, exceptionally well. We have seen very low cases. Again, I think collaboration, wherever we have seen great collaboration between civil society and government, we saw people getting fed, migrants getting transported. So we are realizing that really big problems will only get solved if we work beyond our differences. Today, for example, we are also realizing that because there wasn't great collaboration between governments, what a big price we are having to pay. So collaboration is actually critical to solving problems, whether it is between governments, whether it is between communities, whether it is between civil society and government. I think that is another big lesson that is learned. The third actually is another key area. I know Nachiket has talked about this in the past as well, which is, it's really critical to invest in data, sciences, and insights. For a long time in this fighting this disease, we were actually flying blind. Um, Very, very critical that policymakers realize that it's at least some part of their investments have to be made in investing in having data guide us. And then importantly, that data and the insights that emanate from analyzing that data lead to actions. What is the right time to do a lockdown? How long should that lockdown be? What is the trade-off between economic loss and health aspects? And these all should not simply be because you think you need to do it. Okay. uh, what will be, where if migrants need to move, how much time you need to get them to move before you impose a lockdown? What should happen during a lockdown? I mean, all this should be driven by data, insights, analytics. Very, very important in my mind. I mean, we, for example, in our foundation, as of now, 10% of our total spend has been used for research. We are a small foundation relative to big foundations, But we can spend money for helping BCG studies. We can use it for seroprevalence studies. I mean, large foundations and the government should be doing exactly these kind of things, in my view. And fourth, I think, is there is no substitute at the end of the day. And I've learned this lesson from visiting people like Anand and his family in Gadchiroli, to other travels in other parts of the country. You have to invest in strengthening grassroots organizations and public health infrastructure in the deepest part of the country. If you do not do that, you will not be able to fight whether it's a public health crisis or any other form of crisis. Because the fact is, today, for example, we wanted to send ventilators to remote parts of the country. People told us that they don't even have MD doctors. I know when I went to Gadchiroli, the only MD in that entire district was Anand Bang's mother, right? I mean, what intensivist are we talking about? So how are we going to fight COVID in the district of Gadchiroli, which has a population of 1 million people, right? So at the end of the day, we have to figure out a way how to strengthen the last mile. That is only going to happen by investing very aggressively. Then let this be a lesson. We have to invest in our last mile via, whether it is the government infrastructure. If it's not, then you invest in NGOs who can do that work. You decide what choice you want to make. That's a choice which is worth debating. Let me pause there. Thank you so much.
Thank you. I think, Amit, you hit the nail at the right place. All the 4 points, collaborations, and hitting the grassroots level and working positively towards are very important. And you mentioned about Anand. So I think, Anand, I'll come to you and just share your thoughts. What lessons you are learning, purely from your experience point of view. Anand is on audio.
In that great novel, The Picture of Dorian Gray, Oscar
Yes.
Wilde describes a moment when the eternal youth Dorian Gray looks in the mirror and sees his true picture of a hideous man. I think this crisis has been a similar mirror for almost everything that is wrong in India. I personally point 4 lessons to essentially build on what Amit has pointed very rightly. The Dr. D.A. Henderson, the then Dean of Johns Hopkins School of Public Health, led one of the greatest victory of mankind, the victory over the dreaded disease, smallpox. He once said, "No one has ever thanked me for not having smallpox." And that is the unfortunate tragedy of preventive or public health. So we have large Ayushman Bharat celebrated. On the other hand, the Health and Wellness Center, or the largest community health worker program in the history of mankind, not really celebrated at all, the ASHA program, number one. Number two, the governments in India are completely unprepared for the Black Swan event. And the lesson from this crisis, personally for me, and this I am stating after having worked with political leadership and bureaucrat, I personally realized that governments in India, at least for the foreseeable future, are going to be only at most the median. The outlier, the role to be outlier is going to fall upon the civil society and the private sector. So as Amit pointed out, must invest in them. Number three is Eleanor Roosevelt pointed out, learn from the mistake of others. You can't live long enough to make them all yourself. We seem to be exactly the other way around. We want to learn everything by making our own mistakes, which is not really the efficient way of doing things. And that reduces the effective feedback loop that should be actually available in the government and public health. In fact, the entire human body is a classic example of a beautiful machine which is working on homeostasis, a superb feedback loop mechanism. And that unfortunately is lacking. My worry is that is lacking to such an extent that the political leadership, the bureaucratic leadership is completely bereft of the understanding of the mood of the society, which is overtaking of the leadership. And number four, finally, this goes beyond public health. But as I said, this has been a mirror. We celebrate ourselves to be the largest democracy. I feel democracy is not the election, but what happens between two elections.
Very
And what
true.
happens between two elections is decided by institutions. independent, autonomous, transparent, accountable institution, and said we sorely lock them. And because of that, we have a system which essentially follows three laws of bureaucratic evasion. I'm quoting Nandan Nilekani here. The laws are, we don't need this. It is the job of some other department. It is already being done. And the result of these three laws are visible for everyone. So these are my four lessons essentially from this crisis.
Thank you, Anand. I think you showed the mirror, but it doesn't show the mirror image, but the right image. So I think now I'll move on to the person who really is involved in delivering healthcare. But before I ask question to Dr. Rajiv Bhatt, I think on behalf of the entire Nishith Desai Associates, all the panelists, I thank you being a front runner in this COVID crisis, and we have almost 80 to 90 doctors registered for this session. So I think hats off to you and round of applause for you for serving the patients. And I know, Rajiv, from day zero, you have been operating all cancer patients who required surgery for their survival. So thank you very much on behalf of Nishith Desai Associates to you and the entire doctor fraternity and the doctors who are present on this session today. So, Rajiv, I want your take now, purely from doctor's point of view, oncologist's point of view. And I've seen you and I've been warning you, Rajiv, please hold. You have been operating a lot of patients. Now, what is your take? What did you learn, or what are you learning from this COVID crisis?
The first point that I'd clearly like to make, the first lesson, is that it is unfortunate that it needs an epidemic or a pandemic for us to realize the importance of public health. Angus Deaton, the Nobel-winning economist, said in his 2013 book the very same thing. It required cholera in the middle of the 19th century to realize the importance of public health. The Spanish flu at the turn of the 20th century to do the same. And now in 2020, we need the pandemic to teach us that public health is important. And having, I will have to say here that public health in India has essentially bore the brunt of the attack on the COVID virus and whatever was done at the grassroots level in general. They were doing the surveillance, they were doing the contact tracing. Most of the lab testing was done in the public laboratories. A lot of the care initially was given in the public hospitals. So it did show us that our public health system has something good in it. It also exposed the, and this is where the lesson to be learned, that the public health system is clearly overstretched. It is staffed and the quality is extremely poor. And this is where the collaboration is important. We need to chip in terms of the NGOs, the social service organizations, communities, but most importantly, the private health sector. The private health sector was involved in this pandemic, I think, too late and in an extremely patchy manner. If 5% or 70% of the healthcare in this country is with the private sector, then it should have been involved upfront in a completely integrated and more designed algorithmic pathway. And this didn't really happen, and that led to a lot of non-testing early on, and now so much testing that we are scared that the figures that we are seeing. But apart from these lessons that I have actually learned, I think the single most important thing is that the health of the average Indian citizen is grossly neglected. Neglected at the individual level. We personally neglect our own health. It is neglected at the societal level. It is neglected at the national level. And certainly it is neglected at the policy or the political level. The entire onus should be on prevention, as Amit so rightly said. And this is something we completely forget. How many of us are worried about our health unless we see a mirror like this that shows us how vulnerable we are and shows us that, you could die the next day. So we tend to neglect our health. In India, the average Indian is oblivious to the fact that his health is essentially a glass cage, which can be hit by any passing storm. I'll stop there, Milind. I think for me personally, these were the lessons.
I think excellent inputs from all four of you. And I think what I understand that yes, we are there, but we are not there. So I think I'm curious to know how can we reach there? That is where the there has become very important from public health point of view. So I think I'll move on to Nachiket. I think he has done excellent and fabulous work and has been doing fabulous work on public health. So I just want to understand from you, Nachiket, we understood from all the inputs on this, all for the panelists that actually where we are. But I understand from you where we are today and where we should go, or what could be the ideal scenario 2025. I think talking to and listening to this answer, I think I should have put not 2025, but maybe 2030 or 2035. Because 5 years appears to be a very short duration. But I think I want to understand from you what would be the ideal scenario from public health point of view and how to reach there.
So, of course, there are many pathways. It's not that there is only one pathway. There is my own view, and I've been in public health for about a decade now, trying to understand it from various dimensions, both at the ground level, trying to understand primary care by actually being associated with an outfit that ran it, and participating in a number of policy dialogues with the government, as well as in my tenure with the Gates Foundation. We have to take a somewhat of a pragmatic view as we go forward. Nishith Bhai mentioned the microfinance space. Since the nationalization of the banking system, we had taken the view that government banks will deliver the services to the poor and nobody else needs to bother. The unfortunate reality was that did not happen. And gradually we have now come to believe that it will have to be a mixed response. That is the right response. And no government, even entities as large as the public sector banks have not been able. Similarly, in healthcare, while it is correct that in most countries, with very, very few exceptions, government is the principal financier of all healthcare, not necessarily the provider. In fact, it's an exception where the government is the provider of these services. The famous UK system that we talk about, all of primary care is provided by private doctors. The government pays for it, but actually the provision is done by the private sector. To the best of my understanding, Cuba is the only country today in which a high quality health system runs with government financing and government provision. But there are many countries in which either the government provides the money or one way or the other enables it. For example, in Germany or in Japan, you have to have some form of insurance. There is no way you can be allowed if you're too poor, government will pay. But if you're not, you have to come up. Singapore is the most open system, but even there, you're required to save money for health. You're not allowed to, say, I won't care about it. Now, this would be ideal for India and many countries, Thailand, China, there's a whole list of small and large countries, went from where we were in the 1950s to 5, 6, 7% of GDP being spent by the government on healthcare. This has not happened to us. 70 years have passed. This has not happened. The pragmatist in me says, why don't, and on the contrary, somewhat opposite has happened. As states have gotten richer, take the state of Maharashtra. It spends only 0.6% of its GSDP on health. It's actually UP that spends close to 1.5%, which is why we get the 1%. Gujarat, Kerala, Tamil Nadu, very small proportions of their state domestic product they spend on health. I think we just have to acknowledge that while we should keep exhorting the government to do its part, we cannot now say that unless the government does it, it will not. Because there has been enormous damage done by waiting. One of the things that is always curious, I come from a finance background, banking background many years ago. I was very much observed as a banker the 1991 liberalization. I was a banker prior, I was a banker after. You saw the transformation in industry. Wherever money was spent, automobiles, mobile phones, everywhere, quality emerged naturally. It did not happen in healthcare. 10 lakh crores is being spent by Indians on healthcare. Yet our outcomes are just not
minuscule.
The corporate sector has done what it could, but again, shockingly to me, while there are outstanding facilities and hospitals in the country, the total corporate sector is less than 2% of this 10 lakh. And the largest player is 0.5% of the market. No other industry has this strange characteristic. You take oil and gas, you take banking, you take cement, you take power, no sector. This is a tiny corporate sector, very, very tiny. We have 1 million providers. 95% of them have fewer than 5 employees. So there are nursing homes. I come from a small town. It was earlier a village called Yavatmal. We have healthcare, but there is no large corporate sector player. They are all small players, local players. We have to embrace all this. We cannot now say that let us wait for Kaiser Permanente to emerge. Let us wait for a 100,000 crore hospital system to emerge. It is not going to happen. In fact, even our hospital systems are really not quite hospitals in the way we would understand it from a Western perspective. They're typically places where doctors practice, surgeons practice. Now, there may be exceptions, and I'm not saying that everybody is the same. Hospitals provide the infrastructure that is needed. You're not a patient of the hospital. You're a patient of that surgeon, of that particular doctor. And if the doctor moves, you move to the wherever that individual moves. So really, whatever it is, we have to accept this reality and move forward. I think this has been a big challenge for us from a policy, which is why you see C-section rates in Shravasti of 0.4%, in Pathanamthitta in Kerala 53%, with the public sector higher than the private sector. So we have curious situations. I would say any pathway we find, many experts are here, we have to embrace what is available and see where we can go. And there are many ideas I've written about, not enough time today to talk about them, that can allow us gradually to get to it. But I'm very much with what Dr. Bhatt said, that we have to acknowledge where we are today rather than imagine a world which is, it's not happened in 70 years. I don't know when it will happen.
Thank you, Nachiket. Very important point and eye-opener. So, Amit, now I'll move on to you. And as you mentioned about, 4 very important points, which I think mentioned about key stakeholders. I just want you to tell us who would be the key stakeholders and their roles and responsibilities to getting best possible healthcare, maybe in 2 years, 5 years down the line, and maybe later phase.
Yeah. So, I think, Milind, look, the key stakeholder, as Nachiket mentioned, it has to begin with the government, because at the end of the day, the one thing you find common everywhere is that even if the government doesn't want to be, the provider of services, I think just given the reality of our country where, almost a third of people stay, close to or below the poverty line, I think the government will have to play a very key role in at least making sure that it provides them insurance so that they can access health, whether it's public health, which I think is going to be very difficult for them to suddenly go out and invest in public health, or essentially private health at affordable prices. The government will have to basically be the key stakeholder. So I don't see a magic wand by which suddenly the public health system in the last mile is going to get dramatically transformed in a period of 5-7 years, such that all our health issues are going to get sorted out for 300-400 million people. So I frankly feel that maybe the mechanism we'll have to go forward, I think Nachiket laid the foundation for that point, is that the government will have to basically widen the scope of Ayushman Bharat and the way it is accessed by 300-400 million people in a manner in which health is access to health is available to all. And I think that's probably the way forward. I think there will have to be, however, some way in which the last mile access of public to public health is also strengthened hand in hand, so that at least whatever infrastructure is available becomes functional, so that those two things then go hand in hand, um, and that becomes the backbone of our public health system. I think, but simultaneously, the other thing which I think this crisis had actually completely laid naked is that we probably can invest in hardware, but hardware along with in the absence of software makes no sense at all. Even in a place like Mumbai, we have had, we've had to beg to have doctors and nurses come from Kerala. And that's what I mean by having hardware and no software. And the reason for this essentially is that we have a massive, whichever way you look at the data, we have a massive shortage of doctors and nurses in the system, and that is causing all kind of problems then in the country, and that all of us know exists. Basically, that's an artificial shortage which has been created. You need massive reforms to address that shortage. Dr. Devi Shetty has written some excellent articles on this topic, which anyone can Google and access. It's high time that those issues be addressed, and I think it's very, very important. So I think the government is a key stakeholder in both these issues. The issue of shortage of public health, health personnel needs to be addressed. It will create also enormous employment opportunities, and I think that's the second thing. I think the point that Nachiket makes is a very important point again. um, that there's massive fragmentation, but I think that also creates huge amount of opportunity. I think to some extent there will be a new breed of players who will emerge, and again we have seen some green shoots in this pandemic where technology has started taking a lot of root. Remote services have started coming to light, and part of the reason they came to light was essentially because many doctors and service providers didn't want to go near their patients. And in some cases, the patients didn't want to come into hospitals. I was talking the other day to one of India's most eminent doctors who told me that he was seeing between 15 to 25 patients a day. In his case, basically because he's of advanced stage, but also because many of his patients didn't want to come in. And essentially, I think telemedicine is going to see a big, big fillip. And he was telling me now that he's reconfiguring his entire doctor model in his hospital to give a big push to that. My own sense is therefore that, and it's interesting, he was saying that the cost that he's charging patients is 1/5 of what he was charging earlier for that same service. I think that this could well, therefore, be a very interesting breakthrough. Just like we are seeing a lot more digital payments happen because people are forced to have digital payments. So I do think that there's going to be the corporate sector will be the other stakeholder which will use technology more aggressively to go out and provide a lot more services. And I think they have to be the other stakeholder in all of this. I do think the other stakeholder is at the end of the day communities. I go back to the earlier point that we referred to. Nachiket made this point earlier. Dr. Bang made this point as well. I think in all of this, we realize that without communities, and it's very interesting, even in the West, by the way, the failure in many cases is the failure of communities. You can have educated populations, but where communities have basically been weakened and been divided along ideological lines, you've had massive failure of outcomes. But I think if we can invest more aggressively in strengthening communities and grassroots organizations, we will have better outcomes, be it for public health or be it for other issues that we have to fight. So I think it will be critical for us to do that. And finally, I would say the other key stakeholder in all of this is going to be institutions which are based and steeped in science, data, and research. We need in our country to invest a lot more in that. We cannot outsource all of this to the West. We have to create our own. You know, Nachiket made a reference to a interesting point right in his opening remarks, that some of our learnings, essentially, we were, you know, drawing from lessons from the West. They were irrelevant to us. We will have to basically create our own learnings, because either data is much more, you know, steeped in local learnings, or even otherwise, there is so much that we are learning that you just, you know, cannot just wildly be dependent on, or you know, on the East or the West. You will have to be independent, not because of just political resilience. You'll have to create your own path forward, and I think that's the other point I'd like to make.
I think very important point. In fact, one of the listener, Dr. Sun, also has emphasized on the need of usage of technology like machine learning, artificial intelligence, and managing data and R&D on our own. That is going to play a huge role. So I think it was a very interesting discussion by Nachiket and Amit on role of stakeholders. And so I just quickly want a very quick comment, first by Rajiv and then by Anand. So Amit mentioned about need of personnel, health personnel in India. So Rajiv, can you quickly in few seconds comment on both what Nachiket and Amit mentioned?
Yeah, I think the shortages in healthcare personnel are there for everyone to see. But I want, you know, as far as the key stakeholders are concerned, I think we are missing out on a couple of key stakeholders. See, the government is a very important stakeholder. They have to be in, but I would like to see that as facilitator and moderator, not as controller and regulator. I'll give you a simple example of the Ayushman scheme. You see, they have come in with a lot of price regulation with respect to the drugs, the medical devices, with respect to capping of the, you know, the professional fees, with respect to capping of what corporate hospitals can do, and all this is very well. But at the same time, it doesn't take into consideration the actual costs and viability of the private sector in providing those services. One. Two, who is bothered about the quality of the services that emanate from the use of these cards by people at large? That is what needs to be regulated. You see, the quality of what comes out is not regulated. So it gives a total misconception to people about what this card is all about. I have had patients who come and sit in front of me and say that, doctor, can you give me an estimate for this kind of surgery? And I deal with cancer. It's extremely expensive. So they put 4 cards before me. They have this insurance. This is one. It's about 1 lakh. I have this. And then I have the Ayushman card as well. Remember that this card was supposed to be originally for just BPL. And I have people who come, you know, with these 3-4 cards, and they say, now put all this together and please let us have the requisite treatment, without understanding that there is so much capping done in so many areas that it's impossible to deliver the services. So I'm going to be provocative, and I'm going to say that one of the key stakeholders is the existing medical fraternity. The neighborhood general practitioner is not taken into account when any of these, you know, this kind of planning is done. And I would say that the last mile should be in the urban areas with tertiary care. The primary thing begins in the, you know, grassroots and the periphery. So what I would like to see is to see the entire medical fraternity, including the nursing homes, the small individual general practitioner, being recognized so that they can receive payments from the Ayushman scheme, or in some way people are already accessing them. You see, if I have fever, I'm not going to go to a tertiary level hospital. I go to my general practitioner. He's seeing 200 patients a day. That's my first stop. He's the man I trust. So isn't there some way that that can be facilitated? How can we integrate him? And don't forget that one of the key stakeholders is the Indian citizen himself, because compliance is a big issue. You mentioned about masks, people not using masks, despite all this advertisement and all that. Let me tell you, for tuberculosis, for simple example, there is very little compliance in many pockets in the country with respect to anti-tuberculosis therapy. And we are seeing the results with multi-drug resistant tuberculosis. So we have to factor in the compliance of the population at large. And I think these people are going to be key stakeholders. It may be driven by corporates, it may be driven by industry, it may be driven by NGOs. But at the end of the day, if you ask me what key stakeholders, it's going to be the medical fraternity to the last man. and it's going to be the government as a facilitator, and it's ultimately going to be the average Indian citizen.
Thank you, Rajiv. I think very important. So many eye-opening statements. I am listening to everybody. Anand, your quick take on so far. Very
So
quick.
I will, yeah. So this may be politically incorrect to say in today's atmosphere, but there is something we can and should definitely learn from China. And that was the Chinese declaration from the first People's Health Congress in 1951. The declaration said, how far a mother with a sick baby in her arms can walk, healthcare must be made available within that distance.
Absolutely.
That should be our guiding principle and spirit. With that in mind, and to build upon what Amit has said, the software part of public health system, we have the largest community health worker program, Asha. She can be further empowered. She must be provided with curative role. Without curative role, there is no respect and trust in the community. She only remains otherwise a lackey, not a true liberator for us. In fact, I would go one step ahead and say, why only Asha? We actually also need an Ashok in every single village of India.
Great. I think very important points, and I think I'll shift gears to now Anand and Rajiv. But let me tell you that I've taken liberty and took permission of Nishith Bhai as well as the organizers to extend our session by 15 minutes because I have two or three very important points and the takeaway to be discussed, and we have two, three very interesting questions and comments. So Anand, I think I want your now view. You're working and Amit mentioned about how exactly things are in Gadchiroli, and I've been working with you and you have been listening from you. You are absolutely hitting, maybe whether I call it a bottom of the pyramid may not be a right word, but you are absolutely at a grassroots level. And when we talk of public health, Raju talked about his experience on how the medical fraternity should be covered into entire gamut of public health. Nachiket gave excellent ideas. Amit mentioned about role of stakeholders. But you are there on the ground. And I'm sure you must be facing a lot of challenges. Forget about COVID. COVID is one thing, it's going to stay maybe for a few years. But overall, what are the challenges you are facing to provide access of health to the community where you're working, and what can be done or how you manage?
We have 100 million tribals in India. Now, one can look at them as glass half full or glass half empty. Half full because we are unique, we haven't annihilated them as in many other countries. Half empty because they are literally at the bottom. In every single possible way, socially, geographically, culturally, economically, they are different than from the rural community. Forget the urban community. Just two examples. Who are the source of the largest number of COVID cases in Gadchiroli? The Central Reserve Police Forces, which have been sent to Gadchiroli to quell the ultra left-wing extremism, which is unique in tribal areas, which is unique to central India and the forested part of India. Or take another example. The tribal in Gadchiroli constitute 0.4% population of the entire state of Maharashtra. This 0.4% population has 75% of the total falciparum malaria, which is the deadly form of malaria, cases
Yes.
of the entire state of Maharashtra. So, an extremely disproportionately high burden of certain diseases. In Gadchiroli itself, we have a rural and tribal belt, the rural agrarian tribal forested. And what we see, even the mosquitoes have divided their kingdoms. Culex in the rural agrarian part, Anopheles in the tribal forested part. So even species of animal don't really enter or encroach into each other's territory. So essentially, this tribal is at the bottom. And that is very important also to understand because taking care of the tribal also follows the 80-20 principle possibly of the management because they constitute the largest burden of health morbidity and mortality in India. So I would suggest that focusing on tribal health should be a key priority for the access part. Second part is Rudolf Virchow said, health is politics, otherwise it is
Yes.
nothing at all. Take a
Absolutely.
single example. the long-lasting insecticide-treated bed net has been considered one of the most effective, probably the most effective intervention for prevention of malaria transmission. And I have just shared the load of falciparum malaria in Gadchiroli. From 2000 to 2016, in 16 years, when the requirement was about 3 lakh, the total number of this long-lasting bed nets distributed in Gadchiroli by the government of Maharashtra was around 5 to 7,000 in 16 years. Then something happened. A chief minister who is from this part of Maharashtra came to power, and in next 2 years, almost 10 lakh LLIN are being distributed. So that is the dramatic difference when the political leadership is involved in access and decision making. And finally, third part, and I will close, is that Dr. Taylor, the professor of international health who wrote the Alma Ata Declaration of Health for All, used to say about innovation that public health professionals are like children with key in their hand trying to find the lock. In reality, the approach should be exactly different. Public health professionals should identify the lock and they design the key accordingly. That is then the true innovation. I guess most of our innovation begins with a fixated idea in my mind about what is the access or what is the solution, or then it is the usual buzz around AI, blockchain, smartphone, and app. Essentially, it boils down to just thinking into new ways of acting instead of really acting into truly new way of thinking. So I would propose that for access, we ultimately need 4 types of innovation: in policy, fortification, a good example; in technology, a good LLI which is low cost, not costing 500 rupees, but 50 rupees, another example; in design, reforming the urban primary healthcare system for that matter; and finally, strategy, Nachiket and Gates Foundation has demonstrated a AAA platform combining the 3 frontline workers, the Anganwadi worker, the ASHA and the ANM, they providing and ensuring access is the final innovation. So these, I would say, are the three critical inputs towards access in healthcare.
Excellent. I think very, very true. And possibly people may not be paying a lot of attention to it, or rather the adequate attention to it. So Rajiv, I will move on to you now. And I've seen you changing your hats at a regular intervals on a positive side, right from being your own cancer small setup to a bigger setup to having a stint in South Africa where you're in some kind of public health, and now you are managing the entire cancer hospital. So I just want to of course, you have shared a lot of your views, and I think you got a feedback also on how to take it forward. I'm happy that it happened. But I just want to understand from you quickly, what is your take from your experience as a doctor, cancer surgeon, as you might be talking to your colleagues and friends, and your perspective on public health in India, not necessarily present times, but how do you see it is there and what needs to be done? Anything beyond what we just mentioned? Hello?
Yeah, sorry. So as I was saying, I would like to see increased commitment and deliverance on the part of the government and the political bodies. 1.3% of the GDP on health is farcical, right? It's one of the lowest GDPs even amongst the BRICS countries as well. So where do you go forward with health with that kind of a GDP? 12 states have less than 1% of the gross state domestic product on health. So that I would like to see clearly. The other thing was that the 3-year action plan 2017 that was set up by the National Health Mission said that by 2020 we will be spending 1 lakh crore rupees on health, whereas in actuality in FY20 they've spent 65,000 crores only. So why should this deficit be always there in health? So as far as I'm concerned, for the government, from the government side, I would like to see greater commitment and deliverance. The second thing that I would clearly like to see is integration. Integration between the private health sector, integration between person delivering care in a rural, semi-urban, urban area. Can we not devise a kind of a system based on the NHS model, but which integrates the private health sector, that certain services will be available at a certain level of care, starting from rural, going all the way to urban, and tertiary care only will be available in certain institutions or corporates. Why should, say, a major corporate hospital try to provide basic health care or basic disciplines when that can be done by a regular hospital? So we've got to realign our resources and start integrating, clearly. And the third thing that I would like to see, which we don't focus on, is healthcare. I mean, just to give an idea of the functional outlay of healthcare spending, okay, 54% of it is towards the treatment, actual treatment. 24% is towards the pharmaceuticals and the consumables and stuff like that. And about 12% is towards the other things, the operational costs and all that. Only 7% is part of preventive healthcare spending on a functional basis. Now, this is where things need to change. We've got to realize, and who can do it? Cannot companies or employers say that, look, I want every employee to have this basic level of preventive healthcare. If you is beyond 27, I will cut your take home by 20%. But if you can get it to under 23, I will give you a 10% bonus. I mean, why can't we link fiscal incentive with health? Every employer can do it, and you'll suddenly have a sea change in people's mentality towards preventive health for themselves. And that's where the change will begin.
Great, Raju. I think I've been listening to excellent innovative ideas and thoughts. So, Nachiket, if you want to comment on what Rajiv and Anand mentioned, maybe a quick few seconds. We are just 12, 13 minutes, and I have one or two questions. But your views on what Rajiv and Anand mentioned, Nachiket.
No, I think some excellent points have been made about where we need to go. There is, in all of these ideas is where I think the solutions lie. What is encouraging, listening to them, and what the point Amit has also made so beautifully, that we know where the pathway is. We know where we need to go. I am, for example, involved with an effort that is building a technology backbone. Not so much to do telemedicine necessarily, but to find a way to connect primary, secondary, tertiary to some common framework that allows us to do what Dr. Bhatt was saying, so that each one does what they are good at, but refers up smoothly. Because while we may not have money, we may not have as much government interest, we are strong in technology, we are strong in telecom, we have some of the best doctors across the country. It's so hard to get into MBBS colleges that these are really brightest of the bright people. We have to use them well. And the point Anand also made, the ASHA worker, I mean, if I look at Thailand, they had fewer doctors and nurses than us in 1995. Their ASHA worker of 95 is today's oncology nurse. Our ASHA worker has remained an ASHA worker. What is it? I mean, and Dr. Bang's work in Gadchiroli is a shining example of what you can do with a local person, because we're not asking them to do Nobel Prize winning chemistry. They are doing what is standard routine healthcare, and it can be done with the resources that we have available.
Thank you. Amit, your views?
Yeah, I agree with what all the panelists have said. I think, and I would again like to start with what Dr. Bhatt said. We have to invest much more aggressively in prevention. I mean, I was shocked when I visited Gadchiroli that in one of the poorest districts in all of India, the spend on tobacco and alcohol was a multiple of the healthcare spend of that district. Anand, remind me of what the number was.
The total spend actually is twice the total development budget of the district.
Oh my God.
170 crore total development budget, 340 crore was the out-of-pocket expenditure on tobacco and alcohol.
Now you can imagine, forget the healthcare budget. Okay. I mean, so we have to really get our developmental priorities correct. And I think investing more aggressively in prevention is, I think, the first and foremost priority that we must figure out if we have to have a hope in health. A lot of my work is in the rural and agricultural sector. And I can tell you that a very large part of our bankruptcies at the individual level is because of health issues. So this would be my first point. I think the second point is, look, and this touches upon a little bit of what Nachiket said and what Dr. Bhatt said. We have to reimagine the architecture of our health system. And the time to do it, in my view, is now. Whether it is what the kind of regulatory oversight we have, what the role of technology will be. But I think until we get the entire nuts and bolts right of what our health system should look like, what the role of various stakeholders would be, I think we are not going to be able to imagine, we're not going to be able to get the right set of outcomes. And importantly, I think I agree with Dr. Bhatt that we have to spend more money, but I think given the way our generally spending works, I think the quality of spending in our country is very poor, unfortunately. We will land up wasting a very large part of that money unless we get the architecture right. So I think we must get the architecture right first. And third point I would make is, again, from traveling to different places in the country, uh, one of the key learnings I've had, and I think again, Nachiket touched upon this. I've seen this in Gadchiroli, I've seen this in Kerala. Two shining examples of places where, and Dr. Bhatt pointed this out in case of Kerala, relatively lower spend on health infrastructure. Gadchiroli, the work that Search does is a shining example where I know that their ASHA workers deliver health outcomes, including gynecological outcomes that
obstetric
are
work.
as good as AIMS doctors, pediatricians, right? If you actually invest in process, data, training of last mile workers, you can actually achieve a lot at very low cost. That is what we learn. And so we have to basically invest in the last mile. It does not, just because you spend money doesn't mean you're going to have great outcomes. So I feel that we have to invest more aggressively in that. And I think Search, by the way, the reason why Search gets great outcomes is because there is a set of people there who are maniacal about M&E, or looking at the outcomes on a continuous basis and having that feedback loop. Unfortunately, the quality of spend that we have in our public system is very poor. So we have to basically invest more aggressively in M&E, technology, training, if we have to have great outcomes.
Thank you, Amit. I think we are just moving on to question answer session. But before that, I have just one simple question to all of you, and I want just one or two word answer, not a sentence. That you know, there is a constraint, kind of constraint the policymakers face to reach that circa 2025 robust public health system. So I just want from you one or two things we should or we would do uh, to deal with such crisis in a different way, to deal such crisis in future. Nachiket, your one or two points, quick, maybe two words.
I would say, what Amit pointed out, we need data much better. We have no surveillance capability in the country despite
Okay,
so many years. And I think that's going to be an important issue in the public health.
perfect. Your take?
The
Things.
same as Nachiket.
Okay, city, we call it in our medical language. Anand, your view. One or two things we should or we would do.
Just two. Uh, same as what Nachiket and Amit have said. Just quoting what my father tries to drill in me, bit unsuccessfully. One accurate measurement is infinitely superior to thousand intelligent opinions. We Indians
Okay.
are full of wrong opinions. Better to have measurement. And second, which builds on Gandhi, not universal health coverage, but universal capacity for health.
Great. I think Nishith Bhai taught us that what cannot be measured cannot be managed. That is very rightly said. Rajiv, your one or two points. Rajiv? I think we have him. Before I think then let us move on to I have two very important questions, and after that I'll ask Nishith Bhai to give his few seconds comment. The question is from Sheena Chabra that collaboration works better during crisis. Rajiv, are you there?
Yeah, I'm there.
Yeah, your 2 points quickly.
Basically, it just reiterates that it's data, accurate, and the analytics, and then using that to prepare a kind of a white paper for future contingency utilization. That's what we don't have. We don't have anything to fall back on.
Yeah,
And that's something that is
that reminds me of the good, bad, the ugly. If you want to should, don't talk. Act. So I think
it's in oncology. Can I just very quickly make one point? See, in oncology, we have this debate all the time: real world evidence versus conducting actual clinical trials. We don't need clinical trials if you have good real world evidence based on large amount of data. That's all we need.
Very true. I think we have two quick questions. One is from Sheena Chabra. Collaboration works better during crisis. How do we ensure the collaboration on a sustained basis to address public health issue at a scale? Nachiket or Amit, would you want to handle this?
I will let Amit go on this. He has
Amit?
done the most work in
I know that. Yeah, Amit?
Yeah, I'll be honest with you, collaboration is actually very difficult when you don't have a crisis, and we do try to get people to collaborate. We give specific collaboration grants. I think it all begins by trying to align people around what long-term objectives are. Unless you get alignment done upfront around what a bigger goal is, a sense of purpose, it becomes difficult to achieve good collaboration. So often people do not invest in that upfront alignment exercises. Wherever we have actually done that, you don't achieve it. And the second thing is you need to make sure that you leave egos aside. Wherever you have a set of people where someone's ego is bigger than the others, you generally see things breaking down. So we have a lot of institutions that we've been involved in building. We have a hospital in Bombay, a university in North India, where we've had many talented people involved in building these institutions. We've had no real issues in building them, but it's generally been built on the principle that people will leave their ego when they sit on the table. And so that principle has really worked.
Yeah, thank you. I think there was one very interesting comment by Mr. Praveen Vatelia, Dr. Praveen Vatelia, who is the Vice Chancellor of Kamdini University, that veterinary public health is equally important to pay attention when you want to achieve the robust public health. Now, there is one question from Dr. Snehal Dixit, who is a cardiothoracic surgeon in Surat. His question is a comment, and he needs comment on his comment, that public health should be the responsibility of all players combined with government synchronized efforts. What is your take? Nachiket, you want to just answer this?
No, clearly government has an important role in. If I look at vaccines, for example, nobody is going to pay for vaccines. Government will have to step in and do this work. So I very much, now doctors can help, they can help administer, they can help guide the process. If it's sewerage, if it's vector control, if it is to deal with, leishmaniasis, it's to deal with filariasis, a lot of this, the government has to play a big role.
Yeah, and there is one very interesting comment which we have discussed, Rajiv, you and Amit and Anand all mentioned by Dr. Hemant Sant. He has emphasized on the need of AI, data analytics, machine learning, which is not going to improve overall healthcare, but entire spectrum of healthcare is going to change. So I think that was a great discussion, and I just invite Nishith Bhai to give a few seconds comment, and we wrap up.
So thank you so much. It was such a wonderful, to listen to everybody, and so many ideas have come up. So thank you so much. Very quickly, and we have a few minutes left, so I will not take too much
Seconds,
time.
Nishith bhai. We have a few seconds left.
Okay, that's Indian Standard Time, but I will not. First thing I feel is that use of technology, I personally feel, is very important, and particularly, can we create a cadre of professional health volunteers in every community? And it has happened when sometime in the past wars have happened or some other things have happened, but it is immediately important to have this some kind of cadre. And can we use technology to train people? Okay. Number two, as I mentioned, the technology, it could be both hardware and software. A lot of platforms have come up, but IoT and drones will play an important role in many of the things that we are talking about. As I mentioned, my favorite subject, that spending excessive on the defense. One can always debate the issue, but the proportion of the spent on healthcare is comparatively very low. And in war, nobody wins. No country wins. It's only the companies win. And we should just try to see that we can spend more money on the diplomacy and other kind of stuff. But of course, there are constraints I can understand. But I think healthcare has got very little attention, at least in terms of financial budgeting. That will be good. And can we create a culture of culture of cleanliness and culture of helping each other and stuff like that? So I think culturally, I don't want to go too much deep into that, but I think culture of being the healthiest people, I think that would be very important. I think we have taken some steps, but we can do a lot around that. So again, 2 seconds are over, so not enough time. But I just want to thank again Amit and Nachiket and Anand and Rajiv, and of course all the people on the panel. Dr. Gupta, you did a wonderful job. So I just want to appreciate everybody who participated in the audience. I thank you.
Thank you very much. And I thank you all for uh, staying steady longer, and apologies for extending by 17 minutes.